Carla, it was a wonderful presentation. It was really wonderful. A lot of the questions have come in relation to the actual what you're summing it all up. It's about the lobbying of nursing and midwifery organisations, and also identifying that midwifery is ahead, which it is in several countries. And we will hear from Professor Dunkley Bent now. But a lot of people are asking about that policy. How do we affect policy? How do we influence it? So thank you so much for highlighting that as, sort of one of the main tools that is required in order to change the way nurses and midwives practice. So if you hold on, we'll have some questions in a few minutes. Okay. But what I want to do now is move swiftly over to Professor Jacqueline Dunkley Bent. And Professor Bent is going to talk about the midwife's contribution to improving childbirth outcomes and experience. Professor Dunkley Bent is also an OBE, and she's the first chief midwife for the International Confederation of Midwives. She has an extensive bio which will be up to read, and I would urge you to take the time to look at all of the bios as well, to understand the expertise that's speaking with you today. So I want to pass you over to Professor Dunkley Bent, and thank you very much.
Thank you so much for inviting me, and thank you to all those delegates that are still online listening. I'll try and speak slowly because I'm very conscious that we have no interpretation now. But I'm going to share with you just a short piece about the ICM, the International Confederation of Midwives, and then I'm going to go into the midwives' contribution toward meeting the contribution that midwives, the ICM, are making to the global strategic directions for midwifery in relation to education, regulation, jobs, and leadership. So if we can go to the next slide, please. In relation to the ICM, the International Confederation of Midwives, we are a member organisation, some 139 member associations across 119 countries, serving over 1 million midwives with 100 years of experience of representing, supporting and advancing midwives for women, babies and their families. And of course, we envisage a world where every childbearing woman has access to a midwife to care for her and her newborn baby throughout the antenatal, labour, postnatal period, hopefully picking up some preconception before we start and continuing into that neonatal period. Why? Because the evidence clearly states that if you have a midwife in low and middle income countries, you save lives and you improve maternity experiences, so the experiences of those receiving care. But on to the next slide, please, because of time. I'm going to So we know, of course, I know, some of you know, but for those that aren't familiar with this, midwives educated and regulated to ICM standards and integrated into a well-functioning health system, providing family planning, can provide 87% of essential care for women and newborns, and of course, change the perspective on avoidable harm and avoidable death. So stop avoidable death if they are appropriately educated to the ICM competencies and standards. ICM have competencies for the antenatal, labour and postnatal period. And if midwives are educated to these competencies, then we'll see these benefits. But also averting more than 50% of maternal deaths, improving outcomes, and providing care across the childbirth continuum in homes, communities, health facilities, health centres, and wherever the woman happens to be. I've mentioned the fact that midwives can stop avoidable harm, and that's avoidable death, and of course morbidity for both mum and baby. But on to the next slide, and I'm just speeding up here because of time. But this table here, you'll find this in most of the literature. But if you have universal coverage of a midwife delivered interventions, so if you have universal coverage of midwife delivered interventions, you can avert 67% of maternal deaths, 64% of neonatal deaths, and 65% of stillbirths. And if you even a lesser ambition of 25% increase in coverage of midwife-delivered interventions, you would save 2.2 million lives. And even with a modest coverage of 10%, you could save 1.3 million lives. But this is all caveated. The caveat is that the midwives must be educated to the ICM standards, providing care within an appropriate health structure and regulated. With all those things, you will see the benefits. On to the next slide, please. So how are we as the ICM managing to support our midwives associations to do these things, to stop avoidable death, to step into the space of improving a maternity experiences, respectful maternity, attracting people to the profession, not just attracting them to the profession, but them wanting to stay in the profession and work as midwives? Well, this is one such intervention that we have. It's a universal. This is the ICM's midwifery professional framework. It offers a universal definition of the philosophy of midwifery care based on ethical principles of justice, equity, and respect for human dignity, where all midwifery care takes place in partnership with the woman. It encompasses safe and personal care by midwives with women at the centre. It explains that midwifery care promotes, protects, and supports women's human, reproductive, and sexual health rights and respects ethnic and cultural diversity. It captures the ethos that midwifery care is holistic and continues in nature, grounded in the theory that it espouses. It is standing on the social, emotional, cultural, spiritual, and psychological and physical experiences of women. And you can see there are 10 elements: education, regulation, association, research, midwifery-led continuity care model of practice, leadership and enabling environment, and a commitment to gender equality, justice, equity, diversity, and inclusion. All these things together, implementing this framework, you will see, countries will see, ministries will see that they will move the dial on improving mortality, both for mum and for baby, perinatal mortality. On to the next slide, please. In relation to another intervention, the ICM's midwifery service framework. This framework supports the development and strengthening of midwifery services across countries. It's a tool specifically designed for policymakers, for ministries, for stakeholders, for those who are in charge of health systems. And this tool will work systematically through workforce modelling, the infrastructure that's required to build midwifery services within a safe, regulated, educated environment. And of course, we've seen the benefits of this service, midwifery service framework in countries like, for example, Zambia, where the ministry has embraced this framework and are planning to build midwifery-led birth centres ×3 across Zambia, safely, of course. I would also say, before I conclude this presentation, that we're also, the ICM have deep engagement countries, so they're influencing, we are influencing and affecting change using the professional framework and the midwifery service framework and other interventions like Twin to Win, the Young Midwifery Leaders programme of work, the Emerging Midwifery Leaders programme of work, the Ukraine grant, reducing PPH, etc., postpartum hemorrhage. Our deep engagement countries are Afghanistan, Bangladesh, Kyrgyzstan, India, Somalia, Somaliland, Puntland, Burundi, Senegal. I could go on, but work is happening at grassroots level to try and bridge the gap between our strategic priorities and, of course, to those people that are receiving care. We have evidence-based evidence-based studies that conclude that if you have care by midwives within a primary healthcare facility, midwives are educated and regulated, you will improve outcomes. Midwifery-led birth centres in low and middle income countries will affect this change. And this is empirical evidence published this year. But I will say my final slide to you is final slide, the next slide, is what midwives do will ripple through generations. I've shared an awful lot of data. Data obscures the human experience. The fact that we have 810 maternal deaths every day, these are global estimations, one stillbirth every 16 seconds. The data obscures the human experience, and it's the human experience where the ICM sits with its interventions, ambitions, and more, supporting midwifery associations, midwives associations, to do the best that they can to move the dial on maternal mortality and morbidity, but also to step into that space of where mums and babies thrive. Thank you.
Thank you so much, Professor Jacqueline. There's been a few queries have come in, people looking to see how to join the ICM. So I've been referring them to your website, hopefully for membership, if that's okay with you. And but that slide that you had, the one about the universal health coverage and the range of impact that can be achieved with midwives interventions, is quite eye-opening, even at the 10% intervention. What would you say is the role of the ICM to implement the framework to all countries and achieve maximum midwifery intervention within, by 5 years or by 2035?
So the role of great question, Susan. The role of the ICM is to work through midwives associations. So we have some 139 midwives associations across 120, 119, 120 countries. And it's those associations that are socialising the framework with their health systems and, of course, midwives themselves, ministries. But in our deep engagement with countries, I listed a few, those countries we are really supporting our midwives associations in a really bespoke way to engage with ministries for them to ensure that not only implemented in terms of the framework, but sustainability. We'll only save lives if we sustain the changes that we make.
And I think similar, Jacqueline, to other speakers here today, there's something about a top-down approach, but it's that bottom-up approach from the organisations, from the associations, through the levels of ICM or through universities into policy that's going to help you going forward. So it's a two-way street, really, isn't it?
Absolutely, absolutely.
Okay, thank you so much. Violet, I've had a few inquiries for yourself and people want to share email addresses with you. So I've said that I would send them back over to you, Violet, okay? But in relation, some of the questions were, the questions being asked from the audience are how they would like to know if this programme remains as a postgraduate learning module, or have there been any developments into making this part of the undergraduate curriculum for your nursing and midwifery staff? So what you're doing in the 25 by 25 by 25 BEC, is that something you're teaching to already established nurses and midwives, or are you bringing it into their learning program when they're students?
Yeah, it is already for the already established nurses and midwives, already working, because we find them in the hospitals. Yeah,
Okay.
It is not yet in the curriculum.
Okay.
Yeah.
So that's what they wanted to know. Is this something they're going to learn in the undergraduate, or, before they get their qualification, or after? Yeah.
It is one of our recommendations. It is one of our recommendations, and the curriculum is really being put in place. We are in stages, though not yet approved, but it is in the process.
So that's what they were asking. That's what they wanted to know. Pilar has had to leave, so that's fine. Helene and Carla, loads and loads of questions in relation to how do nurses affect policy. I can't tell you how many there are, right? But basically, what are you doing? What is it? It is quite stark to hear the facts that you've portrayed there, but great to hear the work that you've done. it's been groundbreaking and challenging the political powers to change the work of nurses. Can you tell us a little more about the impact of the nurses being involved in policy development at a political level?
I can maybe start, and Helene can add some points of view. Thank you for the question. I think we have a situation that we don't have chambers for nurses, which is the case for doctors. They do have like work chambers where their interests are formed and brought towards politics, and nurses are lacking the system. I think it might be wanted for historic reasons, and so we thought that it needs to join forces, and so we organized something out of political streams which was not there before. So it's a group of people which we call the coalition of the willing, so to say, people who want to change the system and who are in leading positions in clinics or in other care organizations. And I think the sheer number of people who support the change made it possible to direct the Minister of Health directly. And he invited us into a dialogue about the change. And we were not alone, but there were some interest groups that are, for example, from elderly care, from child care, or other interest groups in care, and they all share the same problems. So I think many papers ended in the ministry, and so the pressure got so high that the system understood that there needs to be a change, not only from workforce shortage, but also from, as Professor McCormick pointed it out very well, from a very framework for good working conditions for people to be interested in learning to be a nurse and providing this job to the population.
Thank you.
Yes, in Germany, so nursing have not a very great lobby, but now it's a big change, and Carla pointed out we are in contact with politics. We are some very strong leadership as CNOs, and we look forward to change healthcare and to show the worth of nursing. And I think now it's time to change it and to set the nurses in another position. And Mr. Lauterbach, we meet him, and he have our papers and so on. And I think he heard of us, because I think nurses are the greatest resource of healthcare. And I think we have an elderly population, and the nurses, we have heard about patient center and family center. And this is the key for nurses to work, and we can get, I think, good positions. We like the job. The nurses want to do nursing, and we can work with physicians and other healthcare professions, but we want to have autonomous situation, and I think we are on the way. I'm a positive CNO. I hope we can do it, and the world help us. We can do it together, I think.
You know, and that's great, Elaine and Carla, and it ties in with Professor Jacqueline was saying too, and you know, it is about the associations as well, and all of these lobbying groups getting, but we've loads of questions coming in from a lot of maybe the lower middle income countries from Brazil and some parts of Africa, also looking to try and influence and not knowing how to do it, you know, sort of thing. So this is great to share this, so to help them set up maybe organizations, or to get involved with some sort of organization to be able to do that. So thank you very much. Just one further question for Dr. Dickinson, really. They said, thank you very much for your presentation. during the pandemic, it was great to see that there was the movement of nurses and APRNs between states. And it is great to see that you have consolidated this practice within the compacts. What other areas do you feel could be changed within the regulatory area to improve how our workforce respond to patient needs? A few people have asked us that about sort of standardizing some regulatory issues to be able to sort of move, you know.
So, I do think one of the things we've worked on, and we do have it, we continue to update it, is what we call our model rules and acts, which are model rules that can be provided to legislators. Sort of gets us a common set, if you will, of regulatory actions that can be implemented across the states. Could that be expanded and shared? I think it certainly can. We share it with our associate members, but that allows for there to be common movement across jurisdictions, at least from a point of saying that I know that a midwife, this is that minimum set of care, and no matter where they're at. This is, so maximum is where we want to go, but at least we know no matter where they're ending up at, that they've had this much education, this is how they're regulated in terms of scope of practice, so on and so forth. So I think that would be something that would be worthy of looking at, a model rules and act that's global. And
I think actually that came from Brazil to Africa to Nepal. You know, everybody's asked the same: have we got an actual WHO or a global standardization of these things? So this is what's been asked on the question. So thank you so much. Now, we're going to move on. I just want to say thank you to the interpreters who I knew had to leave there before the session's over. But I'm going to move on now to introduce you again to Dr. Amelia, who's going to introduce you to Professor Nancy Reynolds. So thank you, Dr. Amelia.
Thank you to all our remarkable speakers so far, and of course, all our partners and ECHO team. I'm honored to introduce our final speaker for today, Professor Nancy Reynolds from the United States of America. Professor Reynolds is the Associate Dean of Global Affairs at the Johns Hopkins University School of Nursing, and she is also the Director of the Center for Global Initiatives and the WHO Collaborating Center for Nursing Information, Knowledge, and Management. She is also a board member of the Nursing and Midwifery Global Community of Practice. Professor Nancy Reynolds, the floor is yours.
Thank you so much for your kind introduction, and it's such a pleasure to be here today, and as a member of the steering committee, to have the opportunity just to say a few words about the WHO Global Nursing and Midwifery Community of Practice and our plans for evaluation. Next slide, please. The community of practice was established and is maintained by the Chief Nursing Office of the WHO, and it was launched about 2 years ago. Next slide, please. And I'm delighted to say that as well as being available through the internet, it's also now available for use by mobile phone, which makes it very convenient. Next slide, please. The community of practice, I just can't say enough how enthusiastic I am about it. That it offers such a wonderful forum for knowledge exchange and discussion among nurses and midwives around the world for better health for all. And just to give you a few examples of the wonderful assets that are available through the community of practice. Next slide, please. It has things such as a library that has the recorded webinars from WHO, courses, resources of the WHO, the ICN, and the IOM. Next slide, please. It has a discussion board forum where members can start a discussion or participate in established discussion addressing different topics of interest. such as nurses interested in political skills, which we've been hearing a lot about today. So this is a great opportunity for people to share suggestions. You can talk about infection prevention and control and many different topics that have been started actually right now. Climate change and COP28 there's a discussion going on that too. The next slide, please. And of course, there's information relevant to our discussions today about the strategic directions for nursing and midwifery. Next slide, please. So now that the community of practice has been up and running for a while, the steering committee has planned an evaluation, and we would be most grateful if you would participate in it. It's really quite short, won't take much of your time, but it would be extremely helpful to us. The link to the Qualtrics survey will be available through the community of practice site, as well as there's a newsletter that's going out that will have a link to the evaluation. It will be anonymous. We are not keeping any respondents' IP address or locations or devices, anything like that. And we'll just ask a little bit about you, your perceived benefits of the site, opinions about features of the website, and any suggestions for improvement. And again, we would be so grateful to you if you would provide us with your input, whatever that may be. Last slide, please. So I welcome any questions from you personally or my colleague, Dr. Angela Chang, who's been very instrumental in putting our evaluation together. So thank you so much.